Thank you very much. I have a question for each of our presenters. First, for Rick, would it be possible to push basic science education into smaller communities distant from traditional academic health centers?
Right. I mean, as we mentioned from the, just from a lecture standpoint, it's possible because of televideo. I do think what's really helped, though, is the basic scientist who's on the ground with the students, who's trying to make sense of all of the information from the basic sciences. But I think with new technologies, part of our challenge, and you're dealing with the very same thing, is moving medical education out into the community, and the basic sciences have frankly been part of the issue with that, because this is highly technical information. It's important for the medical students to have it, but then at the same time they become locked in at an urban center oftentimes. So yeah, I think we can push it out further.
Mary, could you give examples of the types of impact evaluation programs that are being proposed in the community population health training programs?
Yes, thank you for that question. We've had some very interesting proposals, some of which have focused very much on the community impact of the sustained presence of nursing students with them in the community. For example, the changing community attitudes as the nursing students worked with the community to help them advocate for safe routes to school. The community actually began to understand that there were several dimensions to that problem, and it wasn't as simple as simply putting in a crossing guard. It required a change in community attitudes to the appearance of the community and to the engagement of the community. So the impact evaluations have been interesting because, in a sense, they have changed the way the communities have viewed the nursing students, as well as changing the way the nursing students have understood what they have done in the community. I think it's a very promising direction. Thank you.
Thank you. And for Fred Schwartz, what is the next big thing, the next innovation that the School of Osteopathic Medicine of Arizona student learning community might look forward to?
Few things. Number one, we are using our video telecommunication to open the classroom so that our Mesa campus faculty can drop in, because they know when small group is going on. How did my lecture play? I'm a basic scientist and I want to make sure that they're getting the point. I can actually drop in because I know when it's happening and interact with the campus. So that's number one. Number two, every single case that we're presenting to our students for deliberate practice in their clinical presentation education system is now part of an integrated set of virtual community health center families with histories. We use the UDS mapper that the Graham Center put together for COPC to create an environment that is actually reflective of community health centers. And so that's the second major innovation. And the third one is we're taking on the challenge of the longitudinal clerkship as the next major thing we're going to try. It's pretty scary, but we think maybe that we're going to be able to pull that off at a number of our centers.
Thank you. Please join me in thanking the panel. That concludes the formal part of this program. We're actually ending early by about 15 minutes. So I would just entertain the thought that if there, and there's a number of folks here in the audience, include some of the speakers who spoke earlier, if there are questions that you would like to ask of the panelists who have just spoken or spoken before, if that's something that you would like to do, please raise your hand, and we'll work with the web cameras and the microphones and make it happen. Or comments. Well, I don't see anything. I do want to say, I just see something, but please, you in just a second. I just wanted to say, from where I sat and what I heard, it's incredibly empowering in a way to know that this much energy and thought is going on around the type of community-based education, not only nationally but internationally, because of the strong, I believe, evidence that our forum continues to uncover of the need for it and the innovative practices that are being discovered, and the fact that one of our goals is to spread this information, and I think we're achieving that. But let me invite the question here.
Thank you. I'd like to ask a question to Dr. Rick Caliban. First of all, congratulate him on doing basic sciences outside of a major center. Just two questions around that. First of all, how do you find the recruitment and retention of actually faculty? And secondly, you mentioned podcast. We had a similar experience. We've just been podcasting all our lectures that you described. But our students say that it's still a supplement to classroom learning in terms of interaction. How are you addressing that?
I might have to have you repeat the second question. The question on faculty, we were fortunate in terms of finding a basic scientist who had taught for many years in Kansas City and was an outstanding faculty, had won faculty awards. He'd gone to Alaska for 6 or 8 years, and so he'd become more knowledgeable about what it takes to practice in an underserved area, and we're able to recruit him. And so he knows the curriculum. He is able to provide coordination across anatomy, physiology. We use, by the way, in the basic sciences, an organ-based system for better or worse, where they're taught cardiovascular disease and then pulmonary disease and musculoskeletal. But we were fortunate to have him. Then some of the lectures from Kansas City even come down and originate their lectures periodically in Wichita, and we'll meet with the students. Like Dr. Schwartz said, make sure that the students are getting it. But there is still, the televideo is not perfect. A lot of learning occurs after the lecture when you can go in and talk to the scientist in their office and that sort of thing. So it's not exactly perfect, but nevertheless, I think our outcomes in terms of ultimately where these students do their residency, and then after residency where their practice, we've just got this, half of our counties in Kansas are underserved, so we've got to push medical education out away from the urban areas. I'm not sure I got to your second question. Did I get to it? Okay.
Thank you. Question in the back, and please use the microphone or comment.
Good morning. This is a general question, and I come from an outsider's perspective as an evaluator sitting in on the 2 days discussions. And I was wondering, I think Mary's point about the 4 different impact evaluation was wonderful, and I think it's really articulate. And if there's any intention or plans or what's happening at the moment where people are getting together to look at how to evaluate and share tools and findings in that. I think in this day and age, we don't have to recreate things. So it's a general observation and question.
Yes.
This is Zore speaking about the Medical Education Partnership Initiative in Africa. And even just 3 weeks ago, we had a workshop in Kampala where the schools who are doing community-based education got together to specifically address this. And now they are sharing tools. In fact, one of the leaders in evaluating community-based education are both the Uganda and the South African programs that are here. And they are sharing both their stories of their implementation stories, the challenges, the barriers, their tools, and part of the reason why we've established the Facebook page on MEPI, community-based education, is to provide a virtual platform for that. So I'd say, yes, in the African continent, we're seeing more and more the craving to not reinvent the wheel. Of course, all tools need to be contextualized, but it certainly helps when there's something to start with.
I would mention one thing, and that is that certainly evaluation has been a theme of this forum and will continue to be throughout. So it's a very important point that you're making. With any kind of innovation, you have to be doing that to assess the impact. Please. There you go.
Yes, and I agree, and I wanted to say that we're treating this very much as a progression, starting with pilots that are shared, so that we can begin to reach out and get best practices in each of these impact areas. And that requires funding. And we're very grateful that we have a modest amount, but I think we all in this room probably have some interest in generating more impact funding. So that's a very important thing.
So the standard outcome metrics, of course, are mandatory for evaluation for any of the medical schools, and we have all of that kind of data, clinical performance evaluation, student evaluation, the preceptor experience. Beyond that, our faculty are mandated to take a very cold, hard, ice water for blood kind of look at whether it's worth it to do what we're doing, as difficult as it is. And there have been a few, and you'll see some more studies published in the IAMSE journal and other places, looking at the impacts on attitudes, including the patient assessments at the community health centers of the involvement of the students. The informal evaluations that students are able to share with us during sessions on reflection, which are mandatory every week, that we do as narrative medicine experiences, are incredibly moving and motivating for all of us, and some of that is going to be published by Dr. Ratto this year.
Other comments or questions? Yes, one, please.
Thank you. Linda Kasser, representing the Association of Schools and Colleges of Optometry. I have a question for Rick Kellerman. I was very impressed to hear the number of volunteer physicians that you have in your program. I wondered if you could please share your experience on recruiting, potentially training, engaging them, and what rewards do they find of value, of interest to them?
Well, that's a great question, and I don't know. Kansas has this long-standing, it's just part of being a physician, at least, that you volunteer to teach. And it's in Wichita, and it's out throughout the state of Kansas. I'd say it started 40 years or so ago. And it's just kind of progressed. It has, now a lot of the people that teach now came up through this system, and so they learn from volunteers, and it's a way of giving back. Particularly our rural physicians really love to take medical students. Oftentimes, if for no other reason, then they sometimes feel isolated, and the medical students bring new techniques to them or what they learned on other rotations and that sort of thing. And in terms of our rural rotations, it is probably the rotation that the medical students hate the most in terms of having to go to the rural area, and when they come back they always say, that was the best rotation of medical school. So there's just something ingrained. One of our concerns is that as larger institutions come in and physicians are employed, that they're going to be under productivity standards, and that may decrease their ability to volunteer and give some time to teaching. And so we've been very fortunate. We give them a lot of pats on the back, do continuing medical education for free or reduced for them, but we don't pay them. And that may be another thing that we're going to have to do in the future. So we've been very fortunate up till now. I don't like to talk about it because I'm afraid someone will one of our volunteers will figure out that maybe we should pay him.
Right. Thank you very much.
Well, once again, thank you to all the speakers. This has been a great session. I hope the web audience has gotten as much out of it as we have here. Of course, again, if you have questions for the speakers, for any of the speakers, please you send them in to the email address on the website, and we will get those questions to the speakers and invite them to reply. So thank you. We will be reconvening in about a half an hour. Thanks.